All right, awesome. So today our topic is going to be all about starting clinical rotations. Now, I know that everyone on this call today is at various parts of their CRNA career, right? Some of you maybe haven't started CRNA school, but just wanted to jump on and get a head start, just kind of see what to expect. Some people are in their didactic phase and they haven't started clinical yet, but they're going to soon. Some people have been in clinical for a while. And for those of you that have been in clinical for a while, definitely interact within the chat and let the other people know what your experience has been and definitely give some tips, just like we were last time. For those of you that are joining us for the first time, I just want to tell you a little bit about atomic anesthesia. So, atomic anesthesia was started by myself and my co-founder, Sachi. We are both practicing CRNAs. We are both educators and faculty. And we founded atomic anesthesia because we wanted to create a modern platform to support you all through your CRNA school journey. We do have four core values. We do value very much innovation and creativity. We do love educating in an entertaining way using gamification, micro-learning, and all of those buzzwords now that I felt like we were talking about years ago, and now it's becoming super popular. So I'm glad that the academic community is embracing that. Speaking of community, we do value community so much. That's why we've created the webinars so that we can start interacting more with one another across the country, especially in the chats. Just ways for us to kind of feel like we're not so isolated and that we have a big family across the nation. And we do also very much value academic integrity and want to make sure that the information that we give to you is as accurate as possible. So that's a little bit about Atomic. Last time we did a little giveaway. I think we should just keep this giveaway thing going. So we are going to be giving away for this webinar I don't know if you could see it. They are our H&P sticky pads. They're pocket size. And I always love carrying them with me because I could just write down my patient's information really quickly. It's a sticky pad so that I could stick it right on my computer, doesn't leave a residue, and then I give it to the PACU nurses. So we're going to be giving away those sticky pads today, and it's sponsored by Louisa Moya. If you want to say a couple words and introduce yourself to the group, our guest speaker today.
Hello, everyone. I'm an old CRNA. I've been practicing. I graduated in 2001 from Rush University. I've been practicing as a CRNA from a university setting to uh, like a team setting uh, and some independent practice. I've been precepting students. Some of my students, former students, have become chief CRNAs themselves. I had been involved in interviewing applicants, so it's kind of important to me to help our students and get on board, get them ready for actual work when they come into um, their job, when they apply. I am on a different generation. The way we were taught, the way we were precepted in clinical areas is very, very different nowadays. And I would say a lot of improvement. And that is kind of my passion now, is to kind of help people get better on how they can teach the new generation of CRNAs. And I'm very excited to be here and to be of help. And yeah, that's me, old CRNA, and hopefully I can help.
Thank you so much for coming on the webinar today and just sharing your wisdom with everybody. And I think that, Louisa's definitely right. When you meet CRNAs that were trained back in the day versus how CRNAs are trained now, it is a lot different. Things are a lot different. And some preceptors, um, I don't know how to say it except bluntly, has just never been taught how to precept properly, right? And
Yeah.
that's something that we're both really passionate about. I've been precepting residents for over 10 years now, and also teaching academically. And I think that Louisa and I really pride ourselves in being able to connect with residents really well and treating residents well and fairly and getting them to the next step to on with their careers. So thank you for being here.
Thank you for having me.
hmm All right, so here's the QR code. Take out your phones. You're going to want to scan it, and this will take you to the slides for today's presentation. It has lots of detail as we go along. So just to have that in the back of your pocket for when you start clinical. So for an outline for today, so I always like to start lots of presentations off with getting in the right mindset. This is what we did for the time management lecture as well, is just kind of getting yourself in the right groove for approaching this topic and approaching, starting clinical practice. So talk a little bit about mindset and attitude. We're going to go over what your timeline should look like for your growth throughout your clinical journey. A lot of people will ask me, maybe even in their first week or second week, so how am I doing? And I'm like, my answer is always the same. For where you're at right now in your stage, you're doing great, you know? But a lot of people, that's not really satisfactory to them. They want to know, well, what does that mean for how I'm doing right now? So if I show you what a timeline looks like from where you should be at week one versus where you should be at month 18, you'll get a good idea of like where you kind of fall along that trajectory. Louise is going to take you through how to start preparing for your clinical rotations and what to expect for your first day. For those that are already in clinical practice, a lot of this is going to be very, very basic. But for those who haven't started clinical yet, I think this is actually really good because it really does break it down to like the really, minutia of this, your first steps, your first day. A lot of people say that even the basic things were never really taught to them, like, monitors and getting people over to the bed and, starting induction and all of that. And yeah, you learn about these things theoretically, but to actually see practical step by step how to, that's where we're going to go through today. We're going to wrap this up with, again, talking about soft skills, the types of skills that you need to learn in addition to all of the hard skills like your, procedures, your clinical knowledge and whatnot. There's a lot of soft skills that go along with how to do well in clinical practice as well. And then some challenges that you're definitely going to face as you go through this process. So we always like to start it off with some questions. So I love to know where people are from and what institution you're at. So if you want to say, oh hey Sachi's on right now. So if you want to say where you're from, what part of the country, or what institution you're at, what school you attend, or where you work, we'd love to see where everyone's coming from today. Augusta, that was my first teaching job. Long Island, and you're in CRNA School in PA. Awesome. UAB, University of Kansas, Puerto Rico. Nice. Columbus, Ohio. Jefferson. Currently teach at Jefferson. From Georgia. First line. Nice. UAB, Westminster, Indiana, South Carolina. I love seeing people from all over the country. LaSalle. I just reposted LaSalle's picture of the Badge Buddies. That was awesome. Illinois, New Jersey at Villanova. Awesome. Ohio, Florida, NYC and Fairfield, Omaha, UVA. Great. Texas. So, next question. I'm going to launch a poll, okay? So, where are you at with your clinical rotations? You've not started yet, you're in didactics, but you haven't started clinicals. You've started clinical, but for less than a year, or you've been in clinical for over a year. Maybe you're a senior or you're practicing CRNA. So I'll let this cook for 30 seconds or so, and then I'll share the answers. All right, it's slowing down a little bit, so I'm going to end it here and share. So it looks like most of you are in didactics and you haven't started clinical yet. And then a smaller portion of you have not started CRNA school yet. And then some of you have started clinical, but less than a year. Cool. How do I get rid of those markings? I don't know how to get rid of that. There we go. All right, last question is actually two questions. So for those who have not started clinical yet, what are you the most worried about? You could say it in the chat if you feel comfortable. What are you the most worried about? And I have a list of what I think people usually are worried about. We'll see if I matched what you guys are worried about. Power dynamics, yeah, imposter syndrome, difficult airways, walking into the unknown culture, everything. Personalities, yeah, that's a real fear. There's some real personalities in the OR. Taking care of your dog or kids, how you'd be treated as a student, knowing nothing, just sucking. Yeah, all real fears. Freezing and not remembering. Finances and time management. Yep. Looking dumb. Uh-huh. Lack of knowledge. Waking up at 4:30. Bullies. Failing. Finances. Realizing how much I don't know. Yeah. That's that I had all of those same feelings too. Everybody does because you're starting from being at your peak, in the ICU to going back right to the bottom again, right? So those are all real fears. There are just a few people in the chat and on this call that have started clinicals. So, in your opinion, what do you think has been the most challenging aspect of your clinical rotation so far? Maybe share a little bit of wisdom with the group, what you think has been challenging. Maybe it's the same things. Personality management, for sure. Not being hard on myself when I'm not performing as well as I would have liked to. Being told to do something from one preceptor and then the very next day it being wrong. No consistency, for sure. Everyone has a different way of doing things. Yeah, different personalities. Yeah, it's so interesting because a lot of it is not you don't hear a lot of it as like, oh, the cases are hard or like the job, like, the anesthesia part or the skills or the airway. Like a lot of it is just like interpersonal skills. And that's definitely why I added a whole section on soft skills because it's like having these skills to deal with this, right? Deal with the bullies, deal with the personalities, deal with the culture. We'll definitely talk about that a lot in the end. So thank you for that. We have a couple podcast episodes that are directly related to clinical rotations, so definitely check them out. One of them is more specific to starting your cardiac rotation. One, we had a resident come on anonymously and talk about clinicals, about um, pressure of performance and getting over perfectionism and all these other, a lot of the issues that you had talked about in the chat here. And then we also did one about personality traits and soft skills. So check out those episodes. So let's see if I guessed your worries and fears correctly, just from the years of teaching. So stepping into a role in which you are a novice again. Some of you had mentioned that, going from, like I said, going from being an expert to being a novice, that's definitely a huge worry for most people. Don't have all of the knowledge or skills that you need to do the job. That's pretty normal. People will think you are dumb or incompetent. This is a pretty common fear that people have going into the clinical setting. People will be mean or harsh or be bullies. People had mentioned that. You might harm somebody. I think that some people are worried about that as well because this is a little bit more high stakes now. You're a provider. You are having to call more of the shots where you are directly involved in, these quick decision making experiences. So worried about you might, harm somebody. Worried that you did okay in didactic or you passed didactic, but then clinical is a whole nother beast. Will I pass clinical? So that's definitely a common fear as well. People do sometimes worry that your classmates are going to be way ahead of you. You're going to fall behind. So doing that comparison game with one another, that's pretty common as well. And not being able to keep up with everything. So you have didactics now, you have clinicals, you have your DNP project, you have your own personal responsibilities, like somebody mentioned their dog, their children, and then you got to take care of yourself on top of all of that. It feels impossible, right? So did I nail it? Give me a give me a high five or a thumbs down. I mean, like everybody is thinking these things before they start clinical. It's because that was my experience and Sachi's experience and Louise's experience as well, right? So, what are the main goals of your clinical rotation? What are the goals that you should set for yourself and start getting in the right mindset? What are you supposed to get out of your clinical rotation? So you have to then start taking the didactic knowledge that you're learning in the classroom setting and start applying into clinical practice. And we all know there's a big difference between what you learn in the textbook versus what you learn in real life, right? And so it's trying to kind of navigate that, right? What are we learning in the classroom that just kind of doesn't really apply in the clinical setting? What are we learning in the clinical setting that we've never even mentioned in the classroom? So kind of tying those together. Um, Another goal is to expose you to as many cases as possible before you leave the program. So they want to get you through all your specialty rotations, expose you to a variety of patient populations, right? Getting through all your peds, your OB, your cardiac stuff out of OR cases to just give you as much experience as possible. That's definitely a major goal of your clinical rotations. You want to develop a very strong foundational knowledge in anesthesia principles. And ultimately, that is, and then also you want to establish your basic and advanced skills, being able to manage airways, manage lines, do your regional. And then more of those soft skills, improving your leadership skills and your team dynamics. And ultimately, the goal should be to develop into a safe and proficient provider. Always keep that in the top of your mind. This is why you're here. You're here so that you can leave, that you can practice safe anesthesia, and that you are a good provider, that you can handle a variety of cases, a variety of patients, that you have so much versatility in your anesthetic practice. So keep that at the top of your mind. So let's go through a little bit of mindset and attitude again. You might see some of this overlap with some of the stuff I talked about last month, but you are going from being an exceptional and very knowledgeable and very resourceful bedside ICU nurse to once again being a novice, being brand new, not really having any skills at all. And I remember having this epiphany when I was learning some of the didactic stuff, and I was like, when you start realizing how much you didn't know in the ICU, I was like, I can't believe they let me do half the crap I did in the ICU, not knowing all this knowledge, right? You just start having all these epiphanies like, wow, there's a lot that I have to learn. And I thought I knew a lot, and I was like, not even scratching the tip of the iceberg with this. One resident on the podcast said it's a death of an ego. It's learning some humility. There are people that were or are nurse practitioners, right? You're already an advanced practice nurse. You're going back to school again, and you're realizing there's still so much more to learn. There are people that are charge nurses that are leading your unit. You're already a leader. There are people that had other careers before. I've taught people that have been respiratory therapists, that have lots of skills with airway and ventilation. But still, when you go to CRNA school, you have to let all of that go and just be humble, have that humility, and say, okay, I am going to be a humble student again, and just learn as much as I can. And it's hard to let that go. I know firsthand. It's difficult. You have to start changing your mindset to start thinking like a provider now. Okay. Some people have a hard time letting go being a nurse. I know that the word nurse is in our title. but you have to stop acting and thinking like a nurse. You have to start acting and thinking like a provider, like a leader, like somebody that is going to take full responsibility of your cases, take ownership of your cases, right? You're not taking orders anymore. You're giving orders, you're teaching, you're instructing, you're leading. So just getting kind of flipping that in your mind, because I think that when you start taking ownership of your learning and your knowledge, I think you kind of you start how do I want to say it? Uh you learn differently because you're like, okay, well, I can't just cram for a test and dump this material now. I can't just, skim over this. Like I really have to know this. I'm the person now. I'm the provider. You do have to let go of your perfectionism. And I think I said this during the last webinar, there are still providers that I work with that have been experienced providers, anesthesiologists, and CRNAs for 20 plus years that still make mistakes. I work with a very respectable anesthesiologist that I remember like 2 years ago we were inducing, and I wasn't quite paying attention to the order of the drugs that he was pushing, but we always push drugs in the same order. We always put people to sleep first and then we paralyze people, right? And I don't know what came over him. He pushed the paralytic first while the patient was wide awake. And panic set in because we're trying to scramble and get the patient off to sleep. But people still make mistakes, even people that are very, very experienced. So you have to let go of that perfectionism and just really take it with stride that things are going to happen. And then switch from, if this is the type of person that you are, I'm not saying that everybody is, but switch from having a fixed mindset to having more of a growth mindset. And I'll talk a little bit about what that is. So people that have a fixed mindset. So these are people that believe that the qualities that you have, the intelligence and the talents that you have are fixed and they cannot change. They believe that the abilities that you have are innate. These people often avoid challenges in order to maintain the appearance that they're smart. There are people that do this, that they avoid it because they don't want to appear like they're dumb or they're failing or not doing well. These people feel threatened by others' success, and when they're faced with obstacles, they give up pretty easily. And then when they're given any kind of feedback or any kind of criticism, they typically either take it really personally or just ignore it altogether. So I'm sure that a lot of you here know somebody like this, right? That have this more of this fixed mindset. And what we want when we're in this transition period is we want to have a growth mindset. It's the opposite of that. So this is the belief that your abilities can be developed if you are dedicated, if you put in persistent effort, if you are resilient. You believe that your skills and intelligence can be improved. You embrace the challenges and opportunities for growth. You, rather than feeling envy by others' success, you feel inspired by their success, and you persist throughout your obstacles and you seek and you learn from the criticism. You don't take it personally. You try to understand the meaning of the message rather than the delivery. I think some people get caught up on, well, they said it mean. Yeah, okay. Well, some people are just not the most tactful people, right? But if you get to the core of the message of what they're trying to tell you, there's something there that you can improve on. So making that switch, just think about these things and think about how you can improve on having that growth mindset. So ultimately, with your mindset, you want to approach it with a growth mindset. You want to keep in mind that all of your abilities, all of your intelligence can be developed if you are dedicated, if you're persistent, and if you are resilient, and take ownership of your career and become the provider and become the leader. So that's what I have to say about growth and mindset. Now let's talk about your timeline and what your growth should look like through the trajectory of your clinical career in CRNA school. And I kind of broke this up into kind of 6 phases. I gave them all, I tried to give them a name or whatever. So the first 2 weeks or so when you start clinical, you should be pretty much an observer. And I'm going to go through each one of these step by step. You're going to be observing, kind of just taking it all in. People get a little fanatic on the first 2 weeks and then like, oh, I should be like getting my intubations and I should be, I'm like, you should be like learning where the bathroom is and like how to get your scrubs and like those, those like basic things like that. Like, don't worry about getting your intubations, like that'll come. Um, your next 2 weeks after that, you start interacting a little bit more. You're going to be doing a couple airways, attempting some airways and that. But otherwise, you're gonna start like interacting more with the staff and learning where everything's at. Months 2 through 6, so you're going to be integrating a little bit more into your clinical site. I'll go through what those are. 6 through 12, you're going to start initiating a little bit more, initiating your learning. After about a year, you should be, I would say, an intermediate provider. And then after a year and a half to 2 years, you should start transitioning to being an independent provider. We want to train you so that when you start your job day one, you're independent. You can work on your own wherever you go. That your orientation period will just be a couple days to show you where the bathroom's at, and then you're off doing anesthesia. So let's go through each week by week. You definitely have these slides so you can later on, look at, am I where I need to be? So observer, you're just going to learn where everything's at. Where's the parking lot? Where's the scrub machine? It sounds ridiculous and super basic, but people get really caught up on being at like week, or like month 3 when I'm like, you just started yesterday, chill. So like just learning where everything's at. Where's the equipment at? Where's the crash cart? Where's the MH cart? Like, basic emergency equipment. Introductions. You're learning who the staff are, who your student coordinator is. You're learning the culture of the environment. Every environment has a certain culture of the department, learning what OR etiquette is, not touching the things that are sterile, how to interact within the OR. You're going to be observing the types of cases that they do there and the types of patients that they treat. Each hospital setting is going to be very, inner city hospital is going to be very different than more of like a rural hospital, right? So you're going to just kind of get an idea of the types of patients that go there. You're going to start practicing talking to patients. It's going to feel like I remember starting nursing school when I was like 18 years old, 19 years old, and we were like practicing with one another, like how to like do a history. And I just remember it being so awkward. And I feel like I could just go right back to that again when you start clinicals in anesthesia. It feels kind of awkward again. Um, you might do some like bag mask ventilation. You might attempt some airways in your first week or two, but nothing crazy. And then you should be able to perform a basic setup, which Louisa is going to go over. Later on in the month, you're going to start interacting a little bit more. So learning how your didactic knowledge applies to your clinical practice. You're going to be focusing a lot on pre-opping. So learning how to pre-op properly, your H&Ps. You're going to be participating more in inductions and airways in the beginning. That's going to be more of your focus is the induction and airways. You want to be able to prepare for your cases with a detailed care plan based on whatever institution you're at. You want to start learning MAC and NGA for very, very simple and basic cases. They'll probably put you in cases like hernias, lap choles, biopsy, breast biopsies, that kind of thing. Some pretty simple stuff. They're not going to put you in a cranie your first month there. They're going to put you on some easy stuff. Just always know, like in this, later on in the month, know where all of your equipment is at, especially in an emergency. You want to be able to, like, if you're doing a MAC case, you should have your nasal trumpets and your oral airways right next to you. You should have a ET tube styleted in next to you. Just knowing where all your stuff is at when you need it. You're going to be learning how to interpret some of the monitors. So, of course, we know how to interpret vital signs, but the anesthesia machine is going to be new to you. So, learning what all of the different numbers mean, and then learning how to communicate well with the OR staff. So, that's where you should move to. Now we're getting further along. So, you're a couple months in now. So, where should you be at this point? When it comes to your setup and your machine checks, you should be getting into a groove with that stuff. That stuff should come a little bit easier to you now. You should be able to, at this point, interview and examine your patients in pre-op with minimal help. Okay, you should be able to do a basic H&P and do a basic airway exam. You should be able to get patients over to the table with monitors on, have all your equipment and drugs ready without being prompted to do so. You should be able to just do those things. You might not have your airway or your intubation skills down packed yet, but you're improving and you're getting better with your line skills. But I think sometimes at this point, people are like, man, I still can't get my intubations consistently. That's normal. Okay. It's normal that you're a couple months in and you're not consistent with it. You might be able to get a super easy one like ASA 1 or 2, but when it comes to some of the more challenging ones, you don't get it all the time. That's okay. People, I think at this point, obsess over the procedural skills and not obsess over the knowledge skills. Like that's what your focus should be on. You should be focusing on building a base knowledge or of your pathophysiology, your physiology, and your pharmacology, and how all of that is integrated. But people are like, yeah, but intubations. I'm like, don't worry about intubations. I could teach a monkey how to intubate. I can't teach, you have to really focus on all the knowledge that you need to be building in this period. You can be really largely dependent on your preceptor. There's going to be lots of things that you forget. You're going to intubate, you're going to forget to put them on the vent. You're going to intubate, and you're going to forget to turn on your gas. Your preceptor is going to be pretty behind you during this period, kind of making sure that all of these things get done because you're going to forget. At this phase, also, you should immediately notice when things are not right, but you may not know exactly what to do yet. So you're developing vigilance. You should be scanning at all times and picking up, okay, the IV fluid's about to run out. Okay, the patient's bucking. Okay, whatever. Okay, it's they're hypotensive, they're hypertensive. You might not know exactly what the steps are to do yet, but the key part is that you're paying attention and you're noticing. And I think that a lot of people during this point, they're still not picking up some of the tones and cues and people trying to say something to them like table up, table down because they don't haven't developed that ear for it yet, that vigilance. But I think if you can do that, you're on the right track. Now we're getting to the later part of the year, so 6 to 12 months. Where should you be at this point? I think that this is when you're going to start initiating a little bit more. You're going to start developing a little bit more of your leadership skills. You will still need your preceptor, but not as much for like pretty basic tasks and basic knowledge. You know when to take action for basic things. So, like I said, the desaturation, the coughing, and you start taking initiatives to try to fix those things. You try to seek out a little bit more complex cases now, and you start asking your preceptor higher level questions. So we're not asking things like, how does propofol work? We're starting to ask more complex, higher level questions at this point. At this point, you should be able to go through some MAC cases a little bit more independently, especially on healthier patients, and that you can go through a GA induction with pretty minimal intervention. I think that you should be able to get your patients onto the table, monitors on, and go through induction and intubate with very little prompting at that point. You should be able to be left alone for your at least the breaks. People should be able to trust you at this point to leave the room for 15 minutes and nothing crazy is going to happen. And you should, be able to improve your communication appropriately with your staff and without your preceptor. So being able to talk to the surgeon without your preceptor intervening, being able to talk to the circulating nurse, that kind of thing. So now we're getting past a year, and I think this is like starting to be it's like I think this is an exciting part of clinical because now people are starting to give you more freedom, starting to leave you by yourself a little bit more, and you're starting to do bigger cases and starting to do your specialty rotation. So I think that this is like a fun time. It's all fun, but I think this is a cool time. So you start transitioning to being an intermediate provider. You can do basic cases independently. You should be able to do a lap chole or a hernia or a MAC case independently at this point. You may still need a preceptor for much larger cases. So if you're being put into a case like a Whipple or a Craney, you might still need a little bit of guidance for that, but that's okay. Going to start doing your peds, your OB, your cardiac. It's going to feel like day one again because you're learning a new specialty, but at least you have some basic general anesthesia skills. You're starting to do some out of OR cases, so going to the electrophysiology lab, IR, MRI, GI, some of these places that we get put a lot of CRNAs, but you don't get a lot of training in CRNA school. So people will graduate and say, I've never been to MRI before because they've never had that experience. So you should be seeking out those experiences while you're in school so that you have a little bit of, you get some guidance, some advice as to you have some experience. You're going to start learning more complex procedures. So, being able to central lines and regional blocks. You should be able to communicate well with staff, especially when things are not right. You should be able to intervene, but you should be developing trust with people. People trust you that when things aren't right, you're going to say something about it, you're going to do something about it. Last is, I would say beyond 18 months, going to 2 years, you should be transitioning to being an independent provider. You should be able to do general anesthesia, MAC, and regional on most patients on most cases independently. You should be seeking out the most challenging cases and the sickest patients. If you see there's an ASA4 patient, an ICU bedside procedure, some kind of case that you don't see very often, you should be trying to get into that room. You should be aggressive about it, being assertive about it. You should be doing out of OR anesthesia regularly, and by the last 6 months of school, you should be completely independent and ready to get out of there. You should be like, I'm ready to start work. I'm ready to be on my own. Okay. Working on completing your case numbers, helping out others. This is important now. And I could tell when people are ready to leave because this is when they start being a part of that team department dynamic. They start helping out other staff when your cases are slow, your cases get canceled or delayed. You should be going into rooms that you're not assigned to or setting up other people's rooms if you have some downtime and giving educational presentations to staff. The reason why I think this is really important because this starts putting you in a good position for a job offer or a recommendation. A lot of times when you apply for a position, say you don't want to take a position at your clinical site, but you need a position somewhere else, a lot of times they need a letter of recommendation from your clinical site. So uh, maybe you don't want to work at that place, but you want to make sure that people can give you a really strong recommendation that says, yeah, this person is safe, proficient, and they're a good team player, and you start doing these little things. Don't take a lot of time out of your day, but make you look really good for getting that job that you want. This has burned people. Okay. I had a resident was that I had taught that tried to get a job in the Chicago area or whatever. And he, for the most part, did really well in clinical, but kind of towards at the very end, him and his student preceptor had literally one, um, it wasn't even an argument. It was like, I think he just made one snarky remark. And out of the 3 years that he was there and did so well, she was bitter about that and salty about that. So that when they sent her like letter of recommendation thing for him to get this job in Chicago, which was like, halfway across the country, she gave him a bad recommendation. And that kept him from getting the job, which was really surprising. I was surprised that the coordinator did that because he was such a good resident for so long. Some people are petty like that. So just be careful out there. There's some, you just never know. So you just want to don't burn any bridges at the end. So overall, with timeline, I just want to reiterate that, everybody does grow at different speeds. Um, do not compare yourself to one another. I remember there was this guy in my class. His name was Tom Connor. He was like the typical I do love Tom Connor. He was like the typical Penn State frat guy, like very loud, very like he was like the guy that everybody wanted to be friends with, right? And I remember we were like our first week in clinical and we're all kind of like, "Oh, what'd you do this week? What'd you do this week?" And he's like, "I got 4 nasal intubations." And I was like, "What? That's insane." I couldn't even like ventilate my patient. You got like 4 nasal intubations. And I remember like thinking about that for a long time, like, man, I suck. Because you just do this compare game. I mean, we're human beings. That's what we do. It's like impossible. But, you know, it's it's hard to not compare yourself to one another, but just know that This other thing is like people are offered different opportunities too. He got four nasal intubations because he just got put in the room, the dental room that day. Then he got four nasal intubations, right? You're going to get put in different clinical sites. Some people get put in the really busy city hospital with lots of big cases and lots of sick patients. And then I get sent to like the outside hospital that I'm just doing lap cholis for a year. That's just the luck of the draw. Like nobody was like targeting you. That's just how the cards fell, right? So do not compare yourself to other people. If you're looking at this timeline that it gave you, or you're talking to people and you feel like you're falling behind, don't just sit there and not say anything or not do anything about it. Definitely talk to your student coordinator and your faculty as soon as possible. Maybe there are some skills that you need some extra support on, or maybe your student coordinator needs to pay attention a little bit more, and put you with the right preceptors to get you where you need to be. So don't stay quiet. Definitely, bring your faculty in on it and get them because you don't want this to keep going for 6 months, 8 months, and then really are behind and people are like, oh, I don't think we can graduate this person. So just nip it in the bud. If you suspect that, do something about it right away. And of course, be patient. It will come. There's lots of like little micro skills that you need to learn to be successful in clinical. So I'm going to turn it over to Louisa, but I'm going to monitor the chat. So if you wanted to throw some stuff in the chat, I'll definitely answer you here. But I'm going to turn it over to her, and she's going to take you through the next couple topics here.
So everyone, so now you're all ready. You got all the didactic, right? You're all prepared, you studied and everything. It depends on every um, program. Some program, they want you to actually talk to patients before. That's how it was with me in the 1800s. But so you basically know the patient you're going to have. The coordinator, the the program coordinator will tell you, okay, this is going to be what you're going to do. And then so you have time to actually make your care plan, to actually prepare for the cases. So you know what is the medical condition the patient has, what will be the procedure they're going to do. And so you're ready. You have it all written down. But also be prepared, even though you made your care plan, things change and everything is so fluid in the operating room. They might assign you to a different room. So don't fret. Let's say you come in and your care plan wasn't the right one for this patient. I would just step aside and think about it and kind of do your best at that point. And no one should be blaming you if you're not ready for a patient that you were not assigned before. But the expectation is that you know your care plan and that you know your basic, your pharmacology, your physiology, everything, you're ready, right? Now, we have all these different kinds of technology nowadays. In my time, when you have like, oh, a patient has some kind of an exotic disease and you don't know, you're stuck there. We didn't have the reference. You have to go through the books. But now you have all of the access in your phone, your Google search. You can just look it up. What kind of medication is this? What is Plavix? What is this? And what is that? So it's kind of really nice that you have all these access now. So take advantage of all those, you know, apps that you can put on your telephone that you could use. There's an app called Astra. You can figure out, can you do a spinal on this patient? It depends on what are the recommendations. Can you do a deep plexus block for a patient? Kind of like that. So it gives you a very good idea for your care plan. Then I'm guilty about this. I don't get a lot of pediatric patients, but I have a very trusted pediatric apps that I use. And it just has the basic, pediatric equipments, what is expected if a patient's 4 years old, what would be the weight. And I'll share that with you, Ria. It's really a very nice app, simple and easy to use. And then, of course, the NISORA and the local anesthesia calculator. I think that's also ASRA. So that's kind of nice. So you're all ready. You come into the OR, you're all prepared, get a good night's sleep, and just kind of relax. When you come in, be ready when you come in. Presentable. You have to know. Make sure you have your JCO prepared, set up, looking with your scrubs, with your mask and everything all ready, right? And punctuality, it really matters. So be there early to make sure that you got your setup right. So the basic setup, the machine, the airway, and the drugs. And that's all for me. Simple as that. So you come in and you set up the room, and you already go through the checkup machine. Don't rely on the anesthesia tech. Sometimes they have anesthesia tech that does the machine. Don't rely on them. Make sure you check your circuit that there's no leak. Make sure, people forget the suction all the time. Make sure you always have the suction ready with the Yankara ready. And make sure you have your tapes ready. You have your IV set up. You know where to go, where to get them. And at least familiarize yourself with the setup. Like, okay, so this is the Pyxis. On this drawer, there's this medication. And the second drawer, there's this medication. The syringes are here. The IV setups are here. So just kind of get ready. Sometimes some facilities, they do not appreciate it when you draw all the drugs, but just at least you know where they are. But there's some basic drugs that you need to be able to get ready to go, right? Your vasopressors, depending on the case, your induction medications, and your emergency medications. Yep, I agree with you. Open the doors, just kind of keep a mental picture of what is in there, your IV fluids and all that. And then for me as a preceptor, I like it when the student initiates conversation with the patient when I get there. I love it when I come in and I open the door, the setup is great, and then I'm looking for my student. I already know I have a student, and I see the student talking to the patient. It starts the day really, really nicely. It shows you're initiating, you know your role already. You might not be asking the right questions, but it just shows that personality of, this person is going to be great. So that's one tip I'm going to give you for a lot of like CRNAs that you're working with. You show them you do that. That's a good sign already. So introduce yourself. Don't be afraid. Just tell them. And just remember, everyone is just people. They can be like the goddess, the best doctor, the best surgeon in the world. They're just people. So just talk to them, introduce yourself. My name is Louisa. I'm a new student today. It's my first day. Kind of like that. So in my time, it wasn't like that. You just go in there and people yell at you. Nowadays, that doesn't happen anymore. Hopefully that doesn't happen. But I think it's a step forward if you actually introduce yourself to the surgeon, the operating room staff, the PACU nurses, and of course your preceptor CRNAs. It makes everything go smoothly. They know you by name. Sometimes they have boards on the side of the operating room where they write the name of the patient, the surgery they're going to do, and the name of the staff. So that kind of gives you a mental picture of, oh, so the surgeon is Dr. X. So Dr. X, my name is Louisa, kind of like that. And then you write your name in there. Student resident CRNA, resident RRNA. And then people will call you by your name, and it just makes everything so much better. Learn your, next is there, learn your OR environment. Yeah, your sterile technique. I had an episode of a student contaminating the table, and that doesn't go well with the staffing. So learn that the sterile technique, basic sterile technique, and I think 99% of OR nurses, well, I say 100% of OR nurses are very, very, they're not going to be forgiving when you contaminate their field. So basic PPE, yeah. So also, there's something about being too loud in the operating room. And if it is really bothering you, you can speak up. You can tell your preceptor, I can't hear what you're saying, kind of like that. So sometimes the music is too loud. Yeah, there is music in the operating room, by the way. If some of you haven't done your clinicals, make sure that that doesn't interfere with what you're trying to learn. So yeah, and so yeah, that's your first day that you're gonna do. It's kind of funny because it's been 25 years for me, and everything that Ria was talking about, it comes right back to me. all of all of the dynamics of being a student. So yeah. What else am I going to talk about? So this is a basic setup. So for a basic setup, you're going to have your airway. Sometimes the patient will just require an LMA or a traditional ET tube. And then based on your assessment, the patient might need a difficult airway setup. So you're going to have those, eventually to learn. But there are different kinds of blades, the Mac and the Miller, and then the bite blocks, your tape, your nerve stimulator, monitor, suction. Like I said, do not forget your suction, and something to protect the eyes. Make sure that you have that, especially when doing general anesthesia. So this is a basic setup for general anesthesia. What did you say, Ria? Oh yeah, yeah. Make sure that you don't get called a anesthesia. So yeah. Also pay attention for what they need from you. Bed up, bed down, or whatever like that. Now, the basic setup, I went through that a little bit. So your induction agent, and I like to do it that way. Matter of fact, I got involved in designing our Pyxis in our work because I wanted it in a way that medications were arranged depending on how we induce. So I have the induction agent, the local anesthetic, and then I have the muscle relaxant next to it. So it's just in order. And so people were so they don't have to pull out the drawers multiple times. So the basic setup is you have your induction agent. For me is usually propofol. We don't have the barbiturates anymore. Midazolam for your pre-medication. A lot of people give lidocaine before they give propofol because it's a little bit irritating when you push the propofol. Then your muscle relaxant, you can have your depolarizing and your non-depolarizing depending on what you're going to do. And then your narcotics, of course, if you're going to use narcotics. And then your post-op nausea, vomiting medications, Zofran, dexamethasone. A lot of people are using Precedex nowadays. So that one, learn how to use it. And if you're going to use it, a lot of times you have to dilute it. And then your pressors, your usual basic medication we use for hypotension. And then also just know where they are. You don't have to draw them. The beta blockers, the labetalol, the metoprolol, and all those. Just know where they are. And of course, also know where your emergency medications, your epinephrine, your vasopressin, just know if you need it, atropine, if you need them, that you know where they are exactly on your Pyxis or on your drug card. Kind of like that. What else? Okay. So your basic setup, you learn how to use your monitor. Like you're all expert on that because the monitors you use in the ICU is exactly the same. IV fluids, we usually use LRs, sometimes saline for patients that have chronic renal failure, so you don't want to give them LR, and you use mini drippers instead of the high volume. Pediatric, we use a smaller bag of IV fluids. Learn the basics of the computer. For us, we use a Health Connect software. They have different software for anesthesia charting nowadays. Learn a little bit of that. You're not expected in the beginning to know how to use it. Some students don't even have access to it. And so eventually you're going to learn how to do them. It's basic. You guys are way better than us in computer nowadays. So you might teach us more on the other hand. How the bed works, the controls for the bed, the Trendelenburg, so kind of learn the Trendelenburg, reverse Trendelenburg. When you turn the patient, plane the patient to the left, to the right, elevate, and then, of course, make sure also, something I want to make sure you guys remember is to lock the bed when you're moving patients, because you don't want a patient falling when you're asking the patient to move from the gurney to the bed. Your IV poles, we have two IV poles. The reason for that is that you're going to use that for the drape. When you put the sterile field up with the surgical field drape, and we usually clip them on the IV pole. And sometimes you need two IV poles for IV fluids or pressors or whatever you're going to use. We have different pumps, propofol pumps, vasopressor pumps, and all that. IV pumps, you're all familiar with that. You all work in the ICU. Foam pillows. Okay, so a lot of patients that are under general anesthesia, depending on the positioning, you have to make sure that you protect their pressure points, right? The head, the face. So we have special foam pillows when you're doing prone to protect the eyes, all those pressure areas. When you're protecting the arms, we have those foams right here when you're holding the arm, like the patient we're doing thoracotomy, and the arm is lifted this way. We always have to protect the pressure areas and make sure that patient doesn't develop nerve injuries or pressure sores. That's it. I see some. CRNA told me if you mix it, use it soon after you mix it, because if it sits too long, lidocaine and propofol. Okay, so Elena, I've heard a lot of controversies about mixing propofol. I'm sure Ria will be able to give me more information, but I tend to not mix my lidocaine and my propofol. I usually have my lidocaine on one syringe and the propofol on the other.
Yeah,
And
I was saying earlier in the chat that I remember like 12 years ago when I was doing it as a resident, I started seeing like oil droplets start to form in the syringe, like big ones. It looked like olive oil or whatever, because whatever it was interacting. And then I was all worried that I was like, oh my gosh, I'm like pushing this in somebody's vein. And like we know what happens with like fat globules, causing little like
right.
microemboli in there. So I was like, I'm not doing that anymore. I stopped doing that ever since I saw that.
So yeah, so I don't mix them. But sometimes, okay, I'll be honest. Sometimes I'm in a hurry and I kind of want to do a nerve block, and I give them a little bit of propofol. I mix a little bit of lidocaine in it because the patient doesn't feel, they don't yell when it hurts when you're pushing a little bit of propofol. So I use that then. Okay, I'm being honest, I do that sometimes. But for
But I think it's
induction,
okay if you do it right away. It's when it sits there for a while. Like
I
if it's
see, I
like been
see.
sitting there for like an hour or two, then I start seeing
Yeah.
like the oil droplets form.
Oh, okay.
Yeah.
Yeah, so I don't mix them. I usually have a separate syringe for my lidocaine. Um, and then there was a phase in multimodal analgesia anesthesia that we started giving like massive doses of lidocaine to patients to decrease their narcotic. But that has gone out of practice. We don't do that as much anymore. We used to give 1 milligram per kilo before we give the propofol, and then now that has changed. So I usually give very little lidocaine just for the patient. Also, what helps with pushing the propofol for me, that I have based on my practice, is to give it very slowly instead of pushing it quickly. So the first 5 cc I give it slow, and the patient doesn't feel it painful, in the beginning. And then they're too sleepy to complain eventually after 5 cc. So that's my techniques. I'm giving you some techniques for pushing propofol. So that's the basic setup. And there's just some information about like some pearls from me being, having all of these experience from students, is that a lot of the problem is when they come in and they are so nervous, they
Mm.
get paralyzed and they can't think. They know everything, but they can't think. And then we went through a phase as preceptors where we tend to like quizzing students, and they're so vulnerable already. And we tend to ask, okay, how does sucks work? How does this work? And the
Yeah.
students tend to freeze all the time. And it's usually not the best time to ask questions too. Like they're trying to intubate and you're asking them questions. And so we've learned from all that experience, and we're a lot better. Hopefully some of the um, preceptors are a lot better and not do that anymore.
Yeah, for the
My
ones that are in clinical right now, let us know in the chat. Are preceptors still doing mean things like that, like making you answer questions during intubation? I'm curious because they did that to me when I was in
Yeah,
training. Like I would be like literally my second intubation. Okay, okay, we're still getting that. We need to have a talk, a webinar just for preceptors, Louisa.
yeah, I think
Um,
so.
yeah. Because seriously, it's ridiculous. Like I remember like 12, 13 years ago when I was in training, like they were my second intubation and I'm getting asked about all the symptoms of propofol infusion syndrome. I remember I was like, what?
So another
I
thing about intubation, when you get so fixated on getting your intubations, what I want you to do first in your first few intubations is to recognize structures more than getting your intubation. It's like, so you go in there, oh, that's the epiglottis. Okay, oh, that's the whatever. So just kind of recognize the structure. And because that's the basis of being a good, airway person. Don't you
yeah,
think? Yeah.
yeah,
So,
definitely.
yeah. So I have, it's so funny. It really goes full circle because my daughter went to a uh, preceptorship with one of the former residents. She's now a attending anesthesiologist, and she was showing her how to intubate, and she goes, "Oh yeah, your mom taught me this." And I said, "Oh my god, it really came, because I think I remember I taught her that after you intubate, listen to the left lung first, because then if you hear it there, so you're more likely in the lung that you're not main stem, kind of, I think. And so she remembered that, and she was telling my daughter 20 years later, and I was like, oh my god, I can't remember. And she's like an attending now at Cleveland Clinic, and she remembered. So that's kind of nice that um yeah, that people remember.
Yeah,
uh
definitely.
yeah. So also, when people get fixated on, okay, so I was told by this preceptor that um, she wants their propofol on the left side and on the right side and all that. Try not to be affected by that too much, or try not to please the next person by doing what you learn from the other person, because those are very superficial.
Hmm.
Just very pay attention to why they're doing it more than what they're doing superficially. Like they're putting their airway on the left side versus the right, or things like that. Like learn their rationale for doing things. And
Hmm.
then you're gonna have your own technique eventually. You're gonna
Hmm.
have your own system. And so for me, what I tell students, because they were like, well, so and so told me to do it this way. And so my next question is, did she tell you why? And do you think that that is going to be good for you? Like, ergonomically for you? Is it a good thing to do? Kind of like that. So that's how I would approach that. Like
Hmm.
if you feel like
Don't
people are
argue with
giving you,
people either. Like,
yeah,
don't argue with them and don't say the words that will get you crucified, which is I
right.
know. Don't say I know.
Yeah, yeah,
They will hang you for that, you know?
yeah.
So just don't say it, just even though it like kills you. I used to keep like a little notebook with me and I would have everybody's name in there and I would write these things down. Likes the tape this way. likes this, likes that, whatever. I had this like little notebook and I just like before I was working that preceptor, I look at my notes, likes this, likes this, likes this, and I just did it. And it just made my day go smoother because I just didn't have to listen to the ridiculousness of like Louise is saying, this is like minutia, the stuff that doesn't not worth arguing over.
Did you burn that little notebook after?
Yeah, I had to make sure nobody found that notebook.
Yeah. So yeah, those are like little things that a matter of fact, I'm learning from everything you're talking about because I'm in the process of going back to clinicals for my acute surgical pain management fellowship. So
Mhm.
I'm going to be a novice again. So
Yeah,
that's
back
yeah,
in
you're
the
teaching
training
me.
role.
Yeah.
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 It's different though.
Yeah. Yeah. So yeah, you guys, you know, also, another thing I want to mention is, you guys are not nursing students. You guys are experienced ICU nurses. You went through the didactic. Obviously, you're top of the top because you got into a CRNA program. So think about that a little bit. Like I said, it's so easy to fall into that I'm gonna look dumb. I don't even know how to put the EKG. There's a mastectomy, and I put the EKG here, and I'm so dumb, kind of like that. Don't go through that feeling or mindset because you know more than a lot of these people. It's just different. It's just a different field, but you know a lot, and you have a lot to offer to this field.
Yeah, absolutely.
So yeah, so that's one thing I want to mention. I always start with that with a student. It's like as I see them shaking when they're intubating, and I just put them aside, pull them aside, and say, you know more. For goodness sake, you take care of open heart surgery, and this is a small tonsillectomy. You'll be fine, kind of like that. So that's kind of how I build. Um, how do you say this confidence? To acknowledge that they know, that they're not 18-year-old nursing students, that are starting, kind of
Right,
like
right,
that.
right. Yeah,
Yeah,
definitely. So
yeah.
these next couple slides are just getting you through a little bit more of like what to expect for the pre-op and for the intra-op. A lot of this you're learning in your didactic anyway. This is just lists for you to have just to kind of keep it in mind. Some things that you tend to forget are like one thing that's like a big deal, like giving mistakes that people make is like giving your pre-med before all of your safety checks are done. So like giving your pre-med before maybe the patient signed consent. That's just keep those things in mind. Like make sure that patients have all their paperwork done before you just sedated them, because then it's really hard to get consent when somebody's been sedated with midazolam. So, go through these little checklists here for those who are getting ready to start clinical, and definitely reach out to us if you have any questions about this. Um, the induction period, I think that this is probably what we're going to be doing a little bit more of in the beginning is learning induction and airway. Things that people get really caught up on are like the intubation part, but like forgetting everything else. That's important, like blowing up your balloon, connecting to the circuit, turning on your gas. It's okay. Your preceptor's there to help you make sure you don't forget any of these steps. And as you keep doing it over and over again, some of these primary tasks and secondary tasks become second nature. As you're doing your secondary tasks, things that you'll start kind of getting the hang of is like making sure you're throwing on your bear hugger before they put on the drapes, because inevitably it's going to be a time period where you forget to do that. The drapes are on. You're like, oh crap, I forgot to put the bear hugger in on. Or you're crawling underneath the drapes trying to slide it on the patient. And you do that enough that you don't forget to put the bear hugger on. So these things will come over time as you just do it over and over and over again. I would be very clear in the beginning what your preceptor expects you to do versus what your preceptor is going to do. For example, we're not going to expect you to do the charting and do all these things at the same time. So you just have that conversation like, hey, you got the charting. Okay, I'll focus on this. And make sure you clearly communicate with the person that's teaching you. Maintenance phase, lots of things going on here. I think that a lot of people on the outside think that, hey, this is the time that anesthesia sits back and puts their feet up and starts playing Sudoku. And while on the outside it looks like we're doing nothing, there's a lot going on during maintenance. It's just kind of all going on. And here we're constantly scanning the machines, the monitors, the patient, making sure everything's okay, vital signs, whatnot, making sure they're ventilating fine, oxygenating fine, continuing to give them medications like redosing our paralytic, giving our adjuncts and whatnot, fluid management, product management. So there's a lot of problem solving and troubleshooting that goes on behind the drape that a lot of people don't see. And finally, emergence, giving you reversals, titrating off your volatile anesthetic. Extubation is not a big focus in the beginning, but becomes a bigger focus later on. I think a lot of people judge you as an anesthesia provider by how well you extubate your patients. I always ask our nurses, and like, how do you judge CRNAs? And they're like, how well they wake up and if they're in a lot of pain and screaming in pain, right? That's all they see. They don't see any of the other stuff that you did during the case. So learning that finesse with your extubation, learning not to throw the bloody E2 tube all over the sheets or the floor, and becoming a little bit more graceful with that. 1000% how well you extubate. Yeah, exactly. Transporting the PACU. The PACU is a whole nother culture in itself. It's universal. You meet like one PACU nurse, I feel like you meet them all. Or, it's just the culture it's just different. So learning that culture as well. And then your room turnover and you're doing it all over again. Make sure at the end of every day you request feedback. You actively seek it out. Don't just say, okay, peace out, see you later. I'm gonna see, whatever. Take about 5 minutes. Take a deep breath and ask them, do you think today went? Is there anything that I could do better on? Is there anything that if there's one thing that I could focus on to, focus on for tomorrow, what would it be? If you are always asking for feedback, um, keep in mind people may not deliver it in the most tactful or graceful or even the nicest way, right? But you got to kind of see past that and try to get down to what the core message is that they're trying to tell you. And like I said, we're going to be focusing on our growth mindset this year. So we're going to be trying to be better, focus on one thing to do better the next day. So, to wrap this up, we're going to talk a little bit very briefly about soft skills and talk about some challenges that you invariably are going to face during your clinical rotations. So, we call these soft skills, but I think that these are just as important, if not more important, than the other skills that you learn. And I think we call them soft skills because these are skills that are just really not easy to measure. Whereas we can measure, like, can you or can you not intubate? Do you know this knowledge? Do you not know this knowledge, clinical knowledge? But soft skills are just a little bit more difficult to measure. And I think that a lot of these soft skills are really umbrella terms for a lot of little micro skills that you need to learn to be good about these things. So when we say like, I don't know, a soft skill, let's just say like charisma, like as a soft skill, right? What is charisma or what is being like a people person? It's a cluster of a bunch of little micro skills that you can learn that can be taught, so that you become better at that trait or whatever that is. So those skills can be like maintaining eye contact, giving a firm handshake, leaning in and actively listening to people when they talk, repeating things back to people when they talk. These are a bunch of little micro skills that then add up to having this like major soft skill, and you can learn all these things throughout time. So, soft skills, personal attributes that, or behaviors or attitudes that make you interact effectively with other people and engage in various professional and social settings. I think the top five soft skills that you absolutely need to have to be successful in clinical are the following here. You need to be a very good problem solver. We also call this critical thinking. That's like number one. You have to be good at solving problems. You're constantly inundated with things that happen really quickly. Desaturation. Okay. what's going on? I have to figure this out in 30 seconds. Is it an equipment problem? Is it a patient problem? Being able to troubleshoot that very quickly, but also, calling out for help when you need it. Effective communication, also an absolute essential soft skill that you need to have to do well in clinical. Being really flexible and really adaptable. You might have spent all night preparing your care plans for these three cases you're going to do today, only to find out in the morning that when you came in, your assignment was switched to another room, right? And especially as a novice, that's really flustering. And be like, well, but I prepared for room three, and now you're putting me in room four, and you're with a preceptor that's going to start asking you questions for cases you did not prepare for. That's flustering, that's frustrating. But having the soft skill of being flexible and being adaptable and just kind of rolling with the punches is an essential skill for being a really good anesthesia provider. Your cases get changed all the time. Emergency cases get put in your room. You're having to all of a sudden go do a case in the ICU. You have to go do it. That's your job. We're in a service profession. So being really flexible, being really adaptable. I think one of the biggest skills that people need to have is grit, honestly, and resilience. Being able to just keep putting one foot in front of the other, despite being in difficult and challenging circumstances, to just keep going. And that's an essential skill to being successful in clinical practice. Vigilance is also a huge skill. Being organized, being very detail oriented, paying attention, uh, catching little. I would say that the most successful anesthesia providers, it's not that they necessarily notice things when they're out of range. They notice trends or little tiny micro changes in patients' conditions that they pick up because they've just been paying attention that, like, hey, this person's tidal volume has always been around 400 during the entire case. Now it's hanging around like 650 or 600. And it's like, even though that's like still within normal range, that's different for the patient. And you've noticed that. And now you're realizing that, hey, maybe they're getting a little light. Maybe they're about to start coughing in about 30 seconds. It's just that extreme vigilance that you need to have to keep patients safe and being able to just be an excellent provider. Other skills, empathy, EI, EQ, really important. Teamwork, of course, professionalism in all aspects, leadership, becoming a leader in the OR, and like I said again, attention to detail. Like I mentioned, having a soft skill is a compilation of a lot of different micro skills. So if we just take effective communication, what is somebody that has effective communication? What does that look like? People that are effective communicators can educate staff and patients and communicate well in urgent situations or when they have concerns. You can convey complex medical information into an understandable manner. Remember, surgeons, of course, went to medical school, and nurses that you work with are all really smart people, but they didn't go to anesthesia school. So you're trying to explain something that's happening on the anesthesia side of things in a way that they understand that, hey, this is something that's urgent. We need to pay attention to this. People that are good communicators are active listeners and they repeat back what they hear. We also call this closed loop communication. So if somebody says something to you, you are taking what they say and saying it back to them to tell them that you understand what they're saying, right? You're really good at introductions and relationship building. You are talking out loud when you're problem solving. So if you're working with a preceptor and you're trying to figure out what's going on, talk out loud and tell them what your thought process is. So they see that, okay, they can communicate well, they're thinking through this problem. Don't just stand there in silence, try to talk through that problem. Importantly, people that are good communicators are good when they're even under stress. You could be a good communicator when things are chill, but are you a good communicator when shit's hitting the fan, right? Are you still empathetic to your coworkers when stuff's not going well, when you're under a lot of stress? People take things personally. And when you say something under stress, they're just going to carry that with them for a long time. So making sure that you still maintain that effective communication, even when things are really stressful during codes, whatever's happening. And always, of course, being professional in your response. So what are the challenges that you're going to face as we wrap up this webinar? So Everyone's going to face a difficult preceptor. Everyone, no matter where you go. And it's really, take my word for it. You might not believe me, but it has nothing to do with you. Okay. It's not because of you. It's something else that's going on in their life. Maybe things are not great at home. Maybe they, who knows? It could be a plethora of issues that has everything to do with them and nothing to do with you. Okay. Some people are going through a lot in their lives and they are taking it out on you. And that's unfortunate and it shouldn't be that way. And I think that for me personally, when I stopped taking it personally, then I wasn't as affected by it anymore. People are going to be who they're going to be. They're going to say what they're going to say. And unfortunately, you're the one that stuck with them that day.
Maria, I
Um,
want to say
yeah,
something about that too,
yeah,
is
yeah.
that a lot of times when a preceptor is a little bit not allowing you to do something, this like a very typical thing, the preceptor is just not letting you touch the patient or just jumping in all the time, and you're not learning anymore in the situation. Remember that that is not a reflection of you, like what Ria said, and it's a lot of times is a reflection of insecurity of the preceptor.
Yes.
And it
Yeah.
doesn't, it's sometimes it's not a bad thing. Sometimes, the patient is too complex, they're afraid, um, and they don't know when to jump in. Like a lot of times a more confident CRNA knows when to jump in, and they'll still let you do a very complex procedure, a very complex patient. But a lot of times when a preceptor is not as confident in his or her own skill, sometimes they won't let you because they're afraid that you're going to make a mistake and they cannot fix it. So I just want to throw that in. That, yeah,
100% true.
yeah, yeah.
100% true. I found that people that are not as skilled feel like they can't rescue you if something bad happens, right? Whereas people that are more skilled are like, I'm not gonna let this person kill the patient, but I'm gonna let them have a little bit more leeway because I have the skills to be able to back them out of the situation if that occurs, right? Still watching, but still letting you do some more. Like I said, has nothing to do with you, everything to do with the preceptor. Okay. So don't take it personally. Don't let it get to you. Okay. If you're getting feedback and they're just being an a-hole, okay, when they're giving you feedback, when I'm listening to it, I try to be as objective as possible and just pretend that they are talking about another person. It just helps me not get as my feelings hurt as much. But I'm like, okay, we're talking about Susie, my friend Susie, or whatever. Not they're not talking about me, and just listen to the message. Okay, like I said before, listen to that deep message. We there's a lot actually nobody uh was ever taught how to teach or to be a good preceptor. And so there are people that still think about medicine as this hierarchy and treat students poorly and more of the older people, and that's unfortunate that that's the case. And so you'll definitely run into those people that just are just crappy preceptors and you just got stuck with them that day. And keep in mind, like I said, it has nothing to do with you. Um, I try to have, as I get older, I try to have a little bit more empathy for people. I feel pity for people. I feel sorry for people. And I think when I change my mindset to that, rather than being defensive or angry, I just feel bad for them. And that helps me, kind of get through working with them. And then also, to be honest, you just be forthright. Like, think about it. Is there some truth to what they're saying? Even if they're not saying it in the most tactful way, is there some truth? Like maybe what they're saying is like, hey, I don't know. You're not, I remember one time I got in trouble for not acting professional in the OR because I was like showing somebody a picture on my phone, right? And I got in trouble for something like that. And they made a complaint that I wasn't being professional. And I think that initially I was like, but I was t still taking care of the patient. Like the patient was fine, in that period. And I was kind of getting defensive about it. But there's some truth to it, right? I'm a first year resident. I should be paying attention to the patient and not like playing on my phone. And so I think that just be honest with yourself and just listen to the message. If there's some truth to it, take some ownership on it too. There's some ownership for you as well. for that. If anybody wants to unmute themselves and jump in about it, tell a story about a difficult preceptor, please. We'd love to hear it because everybody goes through this. Along the same lines is poor work culture. So maybe just not an individual person, but just the whole place is a mess. The whole place has poor culture, which is hard when you're at a place like that. I always try to find my champions there. There's maybe one or two people there that doesn't give in to all that and is like your go-to person that you can go to when you need to confide in somebody. Maybe that's your student preceptor, whoever that is. Definitely talk to your faculty and just let them know what's going on. You don't want them saying bad things about you because there's anything bad going on. They just a bunch of gossipers there, and it's a bad work culture. So just give your faculty a heads up that something weird is going on there. Remember to remind yourself what your goal is. Your main goal is to go there and learn how to be a safe and proficient provider and to get out. Okay. You're not taking a job there. You're not making friends there. You're not, you're there to do your thing and get out of there. Definitely consider taking up some therapy if you need to. I go to therapy. Lots of residents go to therapy. My insurance pays for it. I'm still a grad student, so my graduate school insurance pays for therapy. Just helps you just kind of deal with these situations if you need it. So don't be ashamed to seek that out if you need it. And all of these are kind of related. Have your support system. Stay really close with your classmates. If you're going through something at clinical, chances are your classmates are going through the same thing. So don't isolate yourself. Definitely, stay open and connected with your classmates. People then have to do away rotation. Some people have to do rotations many, many hours away from their home. Some people have children, and then they have to do a rotation that's in another state. Yeah, that sucks. That's hard. Some people have really long commutes. Um, and when you do these things, it will feel like you're starting all over again. Man, I just got competent spending a whole year at this clinical site. Now I'm at a brand new site again. I feel like I'm starting out day one. It can be isolating, and you just have to keep taking care of yourself mentally, physically. Stay connected. Don't isolate yourself. Frequently FaceTime people, your friends and your family, and just remember that everything is temporary. You will get through this. You're going to be away for 3 months. You will get through this. It's going to look real sweet on the other side. But I know what that I remember being like after my first year, I was like, I think I'm going to drop out. This sucks. I don't think I could do this. I don't think this was made for me. And I remember my student coordinator was like, "You're not dropping out. You're gonna stay, you're gonna stay here. I won't let you drop out." And he definitely kept like my head up. But it's hard sometimes because you feel like you're all alone. So keep taking care of yourself. Keep staying connected with people. The last thing I want to mention is adverse events. So say you have an adverse event with a patient, you make a mistake, there's some kind of bad patient outcome. My advice to you is to immediately report it yourself. The reason being is it sounds a lot better if they hear it from you first versus if they hear it from somebody else first. Okay. They're going to hear about it anyway. Your faculty are going to hear about it anyway. It's going to get reported. So better to come from you. Then they're primed, they're prompted. Then when the coordinator, whoever reports it to them, comes to them and they're like, I already know about this. Okay. So that's my first word of advice is to immediately be the one to report it to your faculty or student coordinator. Take ownership of it and really be insightful as to what led to that event and ways that it could have been prevented. Just like any hospital error, there's usually a series of events that leads up to that event, right? Lots of little errors along the way, lots of little fail-safe things that have happened that cause that to happen. Definitely come up with your own remediation plan and present it. This shows that you are really serious about improving. I would say that residents that we have let go from our program that have made a series of mistakes that led to adverse events, the reason why they were let go was not because of the adverse event itself. It's because these people never took ownership of it. So it was always somebody else's fault. Oh, I mixed up the norepi and the lidocaine infusions because the PACU nurse distracted me. I did this because somebody else did this. And so it's when you're never ever taking ownership of the things that have happened that you have caused, that's what ends up leading you to fail or get kicked out, not the mistake itself. Okay. So keep that in mind. Definitely stay on top of it and show that you're really serious about improving and getting better. So that is all I have for tonight. I know that was a little bit long, but we have it recorded in case you were, doing other things. That's all good. So definitely want to take a couple minutes to, have an open discussion. If anybody has any questions, wants to unmute themselves, we'd love to answer your questions about starting clinical. And don't leave just yet. We're going to do that giveaway. I have one question for the giveaway. Don't sign out just yet. Any questions at all? Awesome. Thank you, William. All right, quick question so I can give away these H&P sticky pads, okay? So first one to put the answer in the chat. Okay. The question is, in honor of the last week of Black History Month, who became the first African American president of the AANA in 1973? Oh, you guys are quick. All right. Seek, Ilias. You know what? I'm gonna take the top three. I'm just screenshotting the top three here because that was so fast. I'm like mesmerized by this. Okay, so we have Ashley, Omar, and Seek. So yeah, the answer is Goldie Brangman. If you don't know her, she's a brilliant, brilliant CRNA, was and started the Harlem Hospital Nurse Anesthesia Program and was the director for like nearly 50 years. She also was the CRNA for Martin Luther King Jr., which is also a really cool fact about her. She's just like a beacon for diversity in the CRNA world, and we definitely love honoring her during Black History Month. So thank you guys so much. Our next webinar is next month, March 26th. We're going to do pharmacology. Y'all know this is my jam. I'm actually finishing my PhD in pharmacology in 2 months. So we'd love to do an intro to anesthesia pharmacology. That'll be a really fun one. Lots of cool stuff coming up. We're making a learning platform that's going to be released this summer. We just launched our YouTube channel, so we have 2 videos up there right now, so definitely check that out. Lots of newsletters, regular podcast episodes coming out each week. And if you're going to the ANA Annual Congress in Tennessee, we're going to be hosting the College Bowl this year, Sachi and I, so definitely come out for that. So thank you all so much. This is fun. Looking forward to seeing you next month. And if you have any suggestions for future webinars that you want to hear, please reach out to us. You can shoot me an email. And any last words that you want to say, Louisa? Thank you so much for coming on. Also, I think that just having somebody with so much experience, it's really great to hear all your advice.
Thank yeah, thank you so much. And oh my goodness, I'm so excited for you, Ria. You're gonna be a PhD coming, and yeah,
Can't believe
so
it.
proud
It's
of you.
been 5 years. It's crazy.
Oh my God. But thank you so much, everyone, for listening to me. And I hope that I was able to give you a little bit of insight, get you ready for when I interview you for Kaiser, and
Yeah.
that you're ready to take on the job. So yeah, this is fantastic. Thank you so much for putting this together, Ria.
Yeah, of course. I'm excited for everybody. I know that this is such a rapid growth period for everybody, but I always say like, nervousness is my I try to turn that into like excitement. I'm not nervous, I'm excited, and
Yeah.
this is a really cool time period for all of you. So thank you all for sharing your evening with us. I'm definitely gonna stay on if you want to hang out and ask some additional questions. It doesn't have to be about this webinar tonight, but otherwise, we'll see everyone soon. Have a good night.
Good night, Ria. Good night,
Good.
everyone.
Thank you. Oh, and for
Maybe
people that won, I screenshotted, but if you want to shoot me your email, if you want to direct message me your email, then I'll get your information and send you those gifts. Awesome. Thank you, Ashley. Got yours. Kylie said, "Do you have any resources for students learning ultrasound and echoes?" Ooh, so I don't know if I'm allowed to announce this yet, but we actually have a partnership coming up with a pretty famous sonographer. Um, that also runs a fellowship program. So we don't have those resources yet, but we're going to start putting that together for you all and including that with our platform that's coming out this summer. So he's going to be doing all of the ultrasound and regional stuff for you all. So that is coming soon. I know that there is a book out there. It's if you look up the NBCRNA bibliography, there is like a ultrasound book on that list that is used for the board exams. But I can't wait to announce when all our ultrasound content comes out. I got your email, Seek. Thank you. Oh, you're putting together a POCUS project. That's awesome. Hopefully, we'll get it out in time for you guys.
That's a quick question.
Yes. Hi, Jasmine.
Hi, how are you?
Good.
Um, Maybe I don't know if some of the people that are still on are the ones that are in clinical. Um, but because I'm still looking at schools, I don't know if that's something that people choose normally as a deciding factor is like where the clinical sites are.
Yeah,
Because
it
um
is.
it is okay. Because of
Yeah.
what you were saying, I can foresee myself, just being isolated and like I'm not a fan of driving anyway. So I don't want to be
Yeah.
driving like, 3 hours to go to a clinical site. And
Yeah,
that's
so I'll give you an example. Like I went to school in Philadelphia, right? There's
Mhm.
lots and lots of hospitals that are within a 1 hour drive. So I never drove more than 1 hour to go to clinical, which works especially for people that have families that can't go to another state to clinical, right?
Okay.
So that is a deciding factor. I definitely would ask during your interview, do you have any clinical sites that are more than an hour away or are out of state or and if they say, yeah, we have, I remember teaching for Augusta and they're like, yeah, we have a clinical site in Jacksonville, Florida.
Oh no.
And so your next question should be, do you provide an apartment? Because I can't
Right.
afford to just live in Jacksonville, Florida for 3 months. So these logistical things are things that you need to
Mhm.
find out during your interview. And if is not good for you, which it's okay that that's not good for you, maybe you need to apply more in like a big city setting, like New York, Philadelphia, that kind of thing, so that you are
Okay.
close to Cleveland, you're close by rather than applying to school that's a little bit more rural. Because if it's
Okay.
rural,
So
you're
like
gonna
a
travel
larger like
metropolitan area.
metropolitan area. Okay.
Yeah.
And
Hmm.
actually I was thinking about that because I had recently reached out to what is it? Bellarmine? It's in Louisville. And
Okay.
like that was one of the in the like she sent me a long email and that was one of the things that they highlighted. They're like all of our clinical sites are here. Like you don't have
Yeah,
to go anywhere. So
that's a big deal. Yeah,
yeah.
that's a really
Okay.
big deal.
Yeah.
Keep in mind also that here's the caveat with that is that in a metropolitan area, you are going to also work in hospitals that have more of an ACT model, which is that anesthesia care team model. So you might work more with anesthesiologists versus more of a rural place, you might work more in independent practice. So that's something that you have to balance too, is like, do I want to work more in an independent practice or am I okay learning in an ACT model? Now, what schools might not tell you is that even though there's a hospital across the street, that the university has an affiliation with, because maybe maybe that hospital has a very strong physician residency program and they
Yeah.
don't allow
Uh-huh.
nurse anesthesia residents to rotate there.
Yeah.
So even though there's a hospital right across the street, you might still have to commute to the other side of the city to go
Yeah.
to a clinical site that they can allow. So there's these weird like dynamics
Yeah.
to just make sure when you're in the interview, you're like, okay, where
You
are the clinical
clarify.
sites?
I did notice that because, like, so I recently started working at UVA, the teaching hospital, and like I'm in CVICU, and so I noticed like there's like three anesthesia people because like one of them is a anesthesiologist, one of them's a resident, and there's like another person, and well, I'm sure this year I don't think the CRNAs do those cases, but they never come up. But
Yeah,
yeah,
yeah.
there's a lot of different people.
The good
Okay.
thing is you'll have option if you have the flexibility to move. There's a
Right.
variety of different like experiences that you can have. You just have to ask the right questions. You know what I'm saying? So like you'll find your right fit out there. You just have to dig a little bit in
Okay.
order to find it. So
All right. Thank you.
good luck to you. I'm excited for
Well,
you.
yeah, it'll be probably another year. So like
Yeah.
just started ICU in January.
Yeah, yeah, yeah.
But like
I
I
mean,
said, I'm
definitely
coming from the OR, so a
yeah,
lot
no,
of the stuff
that's
you're
a good
saying today,
experience.
I'm like, yes, don't do that. No, don't do that.
Yeah. I went to school with somebody who was an OR nurse and we were like I remember being in simulation lab. We could not get the arm boards on the bed and she just went up and was like, whoop.
Oh yeah,
How
that's
did
a
you do
whole, there's
that?
like all these little things are like a whole nother.
Yeah,
All right,
yeah.
yeah, anyway. I
Cool.
remember one day
Awesome.
my anesthesiologist got pulled to another case after our case, and so the patient had already come, and so like I was just like wasting time, and I was at the head of the bed. I'm like, so what are you doing? And I'm like, oh, okay, we're just waiting for anesthesia so we can start giving you medicine. He's like, oh, I thought you were anesthesia. I'm like, no, I'm not. I
You will be soon.
was like, maybe one day, yeah, soon. Thank you guys.
Yeah, of course. All right, I'm gonna say goodnight to everybody. Thank
Okay,
you
good
all for
night.
coming. All
Make it
right,
bedtime.
bye.
Okay, bye.